We're now going to demonstrate volumization of the pre-jowl sulcus and the marionette lines. The pre-jowl sulcus is defined by the mandibular osteocutaneous ligament, which supports the tissue, and we lose deep compartment fat in the deep mental area here. This area is bounded by, as I mentioned, the osteocutaneous ligament, but we also have the facial artery and vein present. The mental foramen is above this area and is not in a region of concern with the injection techniques that I'm about to demonstrate for you. Facial artery comes up, as I mentioned, lateral to the osteocutaneous ligament. The inferior labial artery comes in and is a close relationship to the labiomental sulcus, or labiomental crease, but is deep to the orbicularis muscle. Evaluation, we see that she has increased tone in the mentalis muscle, which creates a deepening of her labiomental sulcus. Botox is going to be a nice way to relax that muscle, and that can be applied strictly to the mentalis. That will help efface that, and so I don't see a need for volume specifically, because I think the Botox will address that. The area here that is the extension of the labiomental crease has lost some volume, as has the commissure of the lower lip, and so we'll demonstrate a superficial crosshatch technique for that area. At the moment, what we're going to do is create a small wheel with the local anesthetic in the central chin, through which a port will be used to access both the superficial and the deep compartments. We'll also use a slightly lateral incision through which our cannulas will be passed. So the needle is first introduced, which will allow us to introduce our cannula. Upon passing the cannula, they go immediately to the pre-perio osteospace, and it glides very easily into that area. There should be minimal resistance. And I always aspirate before injecting, and injection is in a retrograde fashion. The contour is visualized as the injection is made. And you can come and actually feel resistance at that mandibular ligament. Again, we are well below our mental nerve. And we can see how that is now beginning to fill out and even out that jawline. That is a bit cephalad, so now what we will do is come in, and we will be now on, and sometimes even slightly below the mandibular border. The superficial plane from this vector is also safe, and can be accessed through the same port. now we see how that transition between the marionette area or pre-jowl and the chin line is now straight. Okay. So the needle is first introduced, which will allow us to introduce our cannula. Upon passing the cannula, it goes immediately to the pre-perio osteal space, and it glides very easily into that area. There should be minimal resistance. And I always aspirate before injecting, and injection is in a retrograde fashion. Contour is visualized as the injection is made. And you can come and actually feel resistance at that end of the movement. Again, we are well below our mental nerve. And we can see how that is now beginning to fill out and even out that jawline. That is a bit cephalad, so now what we will do is come in and we will be now on, and sometimes even slightly below the mandibular border. The superficial plane from this vector is also safe and can be accessed through the same port. Now we see how that transition between the marionette area or pre-jowl and the chin line is now straight. Okay. The area in the mental crease, as I mentioned earlier, is intimate with the inferior labial artery. However, the inferior labial artery is deep. I like to access this through the medial port. And so the introducer is placed in the midline. Cannula can then be passed in a cephalad direction, being superficial, aspirating, so that we again see that we are minimizing our chance for an intra-arterial injection. And the product is passed. In this area, I like a cross-hatching technique. And so we've now come from medial to central, facing the contour. The second now access point will be from the commissure into the same superficial space. In this distribution, we know that the angular artery is coming from the facial artery, and it averages 1.5 to 1.7 millimeters from the commissure laterally. If we are within that space, we are in a relatively safe zone, as long as we remain superficial to the inferior labial artery. Again, cannula will be used, but this technique can be done with sharp needle as well. And we'll start with the cannula injection for demonstration purposes, and then look to fine needle if further refinements are necessary. And here we're actually passing into the white roll of the lower lip. Supporting that marionette line. Further refinement in the area, as mentioned, can be done with fine needle techniques in the superficial plane. And cross-hatching will allow for effacement of superficial contour irregularities. A little bit more support to the pre-marionette, leveling the transition, or evening the transition between the thicker cheek pad and the thinner area of the pre-marionette. Oh, see, I like that. Excellent. Chin. Maybe use a tiny bit more. Fine needle infiltration can also benefit at this point for refinement, and this is a debow technique. Okay. Here, the depth in this area of the labial mental sulcus is not as deep, and that's not an atypical situation. And so we don't have to add an augment volume in this area. However, we do want to add in the superior marionette region. I do this with a cross-hatching superficial technique, as we are well above the labial artery, and as long as we are within the 1.5 to 1.7 millimeters from the commissure, we are also away from the angular artery. And so in this, what we do is stay, again, superficial, with a cross-hatching technique. Again, now with the space being previously injected, the anesthetic in place, I see a small contour irregularity, which is at the inferiormost border of the mandible. That can be done with either cannula or direct short needle. And so we are going in and doing a more refined placement of the product. Yeah. And that transition of that lower jawline is again aspirating and infiltrating. Okay. No, I like that. Okay, good. We're now going to demonstrate a crosshatch technique, and again, we are within the 1.5 to 1.7 millimeters of the lateral commissure. We are going to be superficial, and we are going to use a cross-hatching technique, where product is simply placed in that subcutaneous space. We will come now from slightly inferior and again into that same space to blend and fill that contour. The pre-jowl sulcus on this side is not as deep, and so I will actually do this with a depot technique. If we look at the contour, we see her fullness just begins to taper off slightly between here and here. We are anterior to the mandibular osteocutaneous ligament and the facial artery, and so if we stay at the periosteal level, we are in a safe zone. And so we will begin with a placement, aspiration to help us understand that we are, in fact, not in an arterial distribution, and move from our area of injection to a more lateral position, which allows that local anesthetic to help us with our comfort. Good. Turn forward. We are now going to demonstrate an augmentation of the deep piriform space. The piriform space is an avascular space. The angular artery at this level appears approximately 3.5 centimeters from the alar cephalad to the nasolabial fold. It does cross about the upper third of the nasolabial fold, and it has a great degree of variability in its anatomy. However, insertion here at the deep space is a safe zone and gives nice augmentation not only to the upper lip, but softens the transition of the superior nasolabial fold. This technique is a depot technique. The needle is inserted and always aspirate and a straight placement into that space. You can see how that nasolabial fold is softened. A feathering or cross-hatching technique can also be used if desired. I actually like it just like that. So we'll come in here, face this side. Nice. The extension of the nasolabial fold beyond the commissure can be addressed through a cross-hatching technique, and that will be done with, again, superficial injections, understanding again this is the territory of the angular artery, but we are within the 1.5 centimeters. However, at the lateral commissure, the angular artery does move medially, and it is, however, about 5 millimeters deep to the surface. So we, by staying superficial in the subcutaneous plane, can feather through both a tangential and linear technique. Placement of the needle, you should not see the gray of the needle. That is intradermal and you are too superficial. And with injection you should see a slight blanching of the skin. The last element of the contouring in this area will be placing Botox into the mentalis muscle. There are 5 recepti from the mentalis that attach on the dermis, and with relative degrees of oral incompetence, contraction of that mentalis muscle creates what we call an orange peel skin. By paralyzing or weakening the mentalis muscle, you not only create smoothness to the chin, but you also help with the depth of the labiomental crease. So injection is actually just off midline on either side.